Good afternoon and welcome to Facebook Live from CGH Medical Center. This is Dr. Bill Bird, Chief Medical Officer at CGH, and I welcome you to the show today. Today the show, not COVID infections, other infections that we have here at the hospital. And I'm going to have a couple of our folks who are heavily involved with that as my guests today. So before I get to infection prevention, let's talk COVID. COVID. All right. I'm going to go U.S. first. In the U.S., BA2 is now accounting for 86% of the cases. You read a little bit about there are variants of the variant now out there, particularly in the Northeast. Have a little bit of an uptick in cases in the Northeast, presumably related to not the BA2 variant, but the variant of that variant, which are a little bit more transmissible even than BA2. So 14-day running average in the U.S., cases are up 22% to 33,691 a day. That's up 22%. Keep in mind, however, that is still way below what it was when we were having some other surges. So 33,000 is approximately 1 in 10,000 people a day are coming down or at least being diagnosed with COVID through testing. So it's still much better than we were at before. Hospitalizations are still at record low levels, which is encouraging. Most likely this is related to the fact that these variants are at least no more mean and nasty than the previous variants, and perhaps even less so. So that's obviously a key thing, is hospitalization, and people that get really sick and or die have definitely gone down, and that's really encouraging. I think Matt has a graph he found that we're going to put up. Yeah, so that just kind of gives you cases, and then anyhow, it just looks good, right? We want to just confirm visually that looks really good right now. So thanks, Matt. In Illinois, as of yesterday, there were 519 people in the hospital. Once again, much better than the height of the most recent Omicron surge, where there were 4,400 people in Illinois in the hospital. And the last number I could find for positivity rate was about 2.3%. which is up just a little bit from where we were at a week or two ago, but still much better than numbers we've had previously. CGH, number of cases that we're seeing a day, low. Number of hospitalizations continues to be low, and or sometimes no one in. So it's been really encouraging lately. I do wonder about these variants of the variants and whether we'll have an uptick in cases, whether that will result in an uptick in hospitalizations here in the next few weeks. As always, we don't know. We'll report it out to you as time unfolds. So if you're someone who's going out and about, and which all of you who are watching, I must presumably are in the community, this person's recommendations would be to live life and go about your business if you happen to be high risk. So, if you're 50 plus and if you have a risk factor, if you're over the age of 65, if you're under the age of 50 but have other high risk factors or immune issues, make sure you're fully vaccinated and boosted to the extent you can be. And then if you do get sick and you're in one of those categories, please reach out to your primary care provider to get set up with some medication to help you if you are sick, because we do have options now to prevent you from getting sicker if you do acquire COVID. As always, during this broadcast, if you have questions, please feel free to send them to me about COVID or what we're going to be talking about next. But I think I have covered COVID for myself, at least today, and I'm going to move on to infection prevention. So as y'all know, COVID has taken center stage in terms of infections here at CGH in our community, state, country, world, the last 2 years. However, we still have the usual suspects of bacteria, viruses, fungi that can cause us to get sick, both here in the hospital and in the community. So what we wanted to do today was to take some time to focus our broadcast on what we're doing to prevent these infections here in the hospital at CGH. And a little bonus we're going to do at the end of our interview, we're going to do another field trip where we go and we talk to some of our staff and you can actually visually see some things that we're doing to try to help with that and how we set up our rooms. So that's the setup. And now I'm going to bring on Gina Superczynski, who is the Director of Quality at CGH, and Katie Pfundstein, who is our Quality Improvement Specialist. Did I say that right, Katie? Is it Pfundstein or Pfundstein?
It's Pfundstein. Yeah.
Okay, I said it wrong. So now I've got it, Katie Pfundstein. So Katie is our Quality Improvement Specialist here at CGH, and she's heavily involved with infection prevention, so we want to have her on as well. So ladies, thank you for taking the time to join me. Not that you had a lot of choice after I started pestering you, but welcome. Are you ready to answer a few questions about infection prevention?
Yeah, bring it on.
Okay, all right. And we talk about this, and it's we're the three of us we were talking yesterday we're kind of nerdy in terms of we're into this kind of stuff. But for folks, just to get some perspective, in some ways I see like these bacteria, viruses, fungi, it's almost like a fourth dimension that's always in us and around us as we live life. And COVID happens to be one that's obviously been front and center, but like I said, in us and around us all the time are these things. And so it's a fascinating topic about what we can do to try to live with these viruses and bacteria, and what we can do and what we need to do to prevent the ones that are going to harm us. So that's why I'm going to start asking Gina and Katie these questions for. So I'm going to start with a simple question. For people who have been in the hospital, they probably see these carts outside the rooms with some verbiage and signage and stuff like that. If you haven't been in the hospital, that's how it works. You walk around and you'll see these carts outside the rooms, and there are different types of isolation. So I'm going to start with the first question I'm going to ask are, what are isolation precautions?
So isolation precautions are used when a patient has a communicable infection. So it's something that can be spread to someone else. So we use isolation precautions. It's asking staff to wear PPE to prevent exposure to themselves and exposure to our other patients. So we have 5 different types of isolation precautions. Contact is the most commonly used one. This is for our antibiotic resistant bacteria. Someone has an infection, MRSA is probably a commonly used term that people have heard. There's other drug resistant.
Would you break that down when you say MRSA for folks who are, what exactly is MRSA?
Methicillin resistant Staph aureus.
Okay.
So it's a bacteria that wasn't initially resistant to that antibiotic, but through overuse of antibiotics has become resistant. So okay. We use a gown and gloves when we're taking care of those patients so that we don't potentially take that organism to another patient. We also have special contact precautions. This is primarily used for C. diff. C. diff is an infectious diarrhea, and it's still a gown and gloves, but when we have somebody on C. diff precautions, we have to clean equipment with bleach because C. diff it requires a sporicidal, something that we need bleach to kill the C. diff. So it clues staff in to clean their equipment with bleach and also to wash your hands with soap and water when you leave that room. We have droplet precautions, which is primarily for influenza. So we kind of got a break from using those last winter, but we've seen a little bit of influenza in the hospital this year. And then we have airborne precautions, which requires a respirator. We commonly see that in a negative pressure room, and that's commonly used for someone who we may be testing for tuberculosis.
And that's the COVID bucket too. Is that right, Gina?
Yeah, it's the respirator, but then we have assigned for isolation precautions specifically for COVID because that requires more PPE than if it was somebody who had tuberculosis. With COVID, you've got the eye protection, the respirator, the gown, and the gloves. And
Okay.
so those are our types of isolation precautions.
Okay, very good. All right, so there's isolation precautions. In our field trip, we're going to give you a visual, more of a visual of what that looks like. I want to move on to another area that you can do in the community, but we do a lot in the hospital, and that is hand hygiene. Who wants to answer the question of what exactly is hand hygiene and what do we have in place here at CGH to help with hand hygiene?
Sure, I'll take this one. So, I mean, hand hygiene is obviously washing your hands with soap and water or a hand sanitizer. And there are 5 moments of hand hygiene in the hospital. So it's before you touch a patient, before you go into a procedure, after a procedure or a bodily fluid exposure, after you touch the patient, or after you touch the patient's surroundings. So our policy at CGH is when you go into a patient's room, you have a hand sanitizer right there. You sanitize your hands, you address the needs of your patient, and then when you leave the room, you have to hand sanitize again. So that's something that to again, prevent all these lovely things from spreading from patient to patient. We have these in place, and we also have secret shoppers. So they actually go around and just kind of keep an eye on our staff to see how they're doing on hand hygiene, if they're foaming in and foaming out as they leave. And then we report that weekly at our safety huddle, and then quarterly we kind of disperse the information out to all of our departments to say, you're at 95% compliance for your hand hygiene. Something we've done recently, we have nursing skills. So it's the hospital nurses, the CNAs, and the radiology department. And they all come and they do their hands-on activities. And we've been able to do a hand hygiene experiment with them. So they all put on a pair of gloves, and I give them some red paint, and they have to rub their hands together like they are putting on sanitizer, but they have to close their eyes. And after 20 seconds, they open, and then we see if they have any white spots left over to kind of just be a visual reminder of places that they've missed. So that's been really eye-opening, I think, for people, because you tend to rub your hands together the same way when you're done with sanitizer. So yeah, so it's just something.
Katie, I'm going to interrupt you. For the people that are watching, who want to wash their hands well and everything when they're out and about, where do people typically miss?
Well, their knuckles in between, and their opposing thumb is typically a lot
opposing thumb. So if I'm right-handed,
your left.
Your left thumb. Okay, if you're left-handed, your right thumb.
Yes.
So it's knuckles between the web spaces. Okay.
Yep.
All right. Those are the spots. All right. Good for folks to know when you're trying to wash your hands. And I'll tell you another thing that I've experienced is they recommend 20 seconds, right, to wash your hands for 20 seconds. That seems like forever. Now, for the alcohol, if you're using alcohol like a sanitizer type of thing, how long do you rub your hands if you put sanitizer on?
I rub it until it's completely gone, like until it's completely dry.
Well, it's not a number of seconns. It's just
until it's correct. It's until my hands are dry. That's
okay. All right. And this has come up before, obviously, with COVID, when we was really concerned about the surfaces and stuff. But in general, when you put on hand sanitizer, how much would you put on your hand, Katie, when you start rubbing?
Like, is it a dime, nickel size? I don't know. Ours puts out way more than that, but I would say, Gina, what do you think?
Just enough to cover the surfaces to get everything wet.
Yeah. Okay. I'm become kind of a hand sanitizer titrator, I guess you'd say. Like, if all I do is grab a doorknob and I just grab it with my right hand, I'll just put enough on my right hand that I can just kind of real quick rub that area there, and I know that I'm good to go. Whereas if I've been grabbing a bunch of different stuff, I'll just do the dab on my hand and wipe it and everything like that. So, okay, we are getting in the weeds. Okay, that's all right. Like we said, we're kind of nerdy about these kind of things. That's our job, to be that way. So, Foley catheters. So I want to talk about that next. It's first, I'm gonna whoever wants, or maybe both of you want to take this on. What exactly are they? Why do we use them? What's the value of them? and what's the concern with them, and how do we address that concern in terms of infection prevention? There you go. I'll let you ladies
All
take
right,
it.
I'll take this one. A Foley catheter is a urinary catheter. So it's a thin, flexible tube that's inserted into the bladder to drain the urine, and typically we have it drain it into a bag. There are specific indications for Foley catheters. It's for accurate output in a critically ill patient. For if someone is incontinent and they have wounds in the area that would become moist from that incontinence. If it's someone who's at the end of life, so it's for comfort. If someone has urinary retention, so their bladder's full but they can't empty it, so we would use this to empty their bladder, and then we use it during surgical procedures. So those are the indications for urinary or Foley catheters.
Yeah, so it's a good thing. I mean, it's great that we have Foley catheters. Yeah.
Yep. So what we do here at the hospital is every day the nurse has to assess whether there's a need for they have to chart whether they're meeting these criteria. So if a patient had it for a surgical procedure but is no longer indicated, then they assess it daily. And then if they say, wait, we're not meeting criteria anymore, they're going to speak to the provider and ask them if they can take the Foley catheter out. We want to, Katie and I think we're the Foley police, I'm sure some people would say about us. Infection prevention has to look at all our Foley catheters daily to make sure that they're meeting, we have to assess it for urinary tract infections that you could get from a catheter. So we have to look at them every day, but they get friendly calls from us. Hey, do we still need this? Can we take this out? We have some alternatives. We've implemented external catheters in the last few years. So, that's an alternative to the Foley catheter, which wouldn't cause less risk for infection with those. So we're also kind of the police, as you might say. And then, it's important to get them out as soon as possible because it's a foreign object in your bladder. So when you have that in place, you're increasing the risk for urinary tract infection. So They have their purposes, but we don't want to use them any longer than we need to.
Sure. Another aspect of this is that when we put the catheters in, we want to try to do that in as clean a method as possible, because that also is you want to have a clean insertion as much as you can, because that helps with the risk of that foreign body causing infection. So Katie, you want to talk a little bit about what we do for that?
Yeah, so we actually have a kit that we put together for the pericare piece of it. And so our CNAs can grab this kit, and then it has all the wipes, it has everything they need to properly clean the area twice a day. And that's been really helpful for our staff to be able to have that piece and just help keep things as clean as possible.
Anything else you'd add to that, Gina?
And we do our weekly, rounding on all our Foleys as well. Katie does that with some of the educators too. We've got a checklist to make sure that we're all following the proper, proper techniques and procedures with our catheters to make sure we're lowering the risk of infection.
Is there a time frame that we ideally want to get those out within?
As soon as possible.
Yeah, because every day that goes by that you have one in, obviously there are reasons that people need those in. But every day that goes by that you have that in, the risk of that infection kind of begins to go up. So, yep, that's good. Thanks for that. I want to talk next about something else that's pretty invasive, but there are indications for it. And basically, I'm going to ask you the same questions that I asked for the Foley catheter about this next thing, and that's something called a central line. So I'll let whoever wants to kind of tackle that one, what the central line is, and all those other questions that kind of roll into the infection prevention part of that.
Sure, I'll take this one. So a central line is similar to an IV, but the tubing that's in it actually goes into a vein pretty close to your heart. So you can get medicine through it, you can get blood products, you can get nutrition. It's meant for people who are fairly sick and need medication for a longer period of time, because you can leave it in longer than an IV. We also have, it's called a Picc Line. It's a type of a central line that we put in for patients who need antibiotics for weeks at a time. So that's something, again, very helpful to have here. Some patients don't have very good IV access, so we can put in a central line. But again, there are still risks to having an infection. If it's emptying into your heart, you don't want any bacteria to getting in there or anything like that. So again, daily we have an email that infection control reviews every central line in-house to make sure that it's still needed. Weekly, we round with the nursing educators on the floor just to make sure that the dressing that's over the central line looks clean. There's no blood or anything underneath it. And making sure we have alcohol caps on all the lines to, again, just make sure we can't get anything inside of it to introduce any external bacteria. So,
Yeah. Because if folks get a central line infection, they can get pretty sick.
Yes.
And can stay sick for quite a long time. So just like we talked about with the Foley catheters, Katie, would you talk a little bit about what we do to make sure that we when we put in the central line, which typically goes right in this area here in your chest, kind of like along that area, what we do to make sure that is done in a clean fashion, because that obviously will reduce the risk of getting infections as well.
Absolutely. So we actually have a checklist. Again, it's like a sterile field procedure. So we drape the area and use all of our sterile processes. We've got like I said, a long checklist that everyone follows to make sure that everything, you're using your sterile gloves, you're using sterile technique to clean the site and to access it and all of that as well. And we track that as well to make sure that our compliance is acceptable, that we are following all the steps that we need to.
And this whole checklist, following a process, doing timeouts, all that kind of stuff sounds like, oh yeah, fine, great. I think it was less than 20 years ago that I think it was in the state of Michigan, someone did a study, and they did like a checklist type of thing compared to the non-checklist. And the results were startling in terms of the number of infections that people were getting from central lines who did the checklist versus who just kind of did it however. So once again, it's one of those hindsight of, oh yeah, that makes sense. But it's relatively new in the healthcare field that we do these checklists for central lines, and it has made a remarkable difference in the number of central line infections. So I just wanted to add that to what Katie had to share. So that's our central line infections here at CGH are very few and far between.
Yes.
And that's
and like everything, with COVID, we saw patients that were in house for a lot longer than we ever had seen before too.
Yeah.
And that a longer time with the central line, longer time with the Foley in. So, we did see some hoops we had to jump through with all of those longer stays as well.
Sure.
Mm-hmm.
Okay, we're going to talk about what we do for people that are going to the operating room to try to keep them from getting what's called surgical site infections. And it's a program that we started, I don't know, within the last couple of years. I don't know. Anyhow, it's called Nose to Toes. And who wants to kind of talk about Nose to Toes?
I can talk about that. So Nose to Toes it's a decolonization protocol. So by decolonization, basically we're doing several things to try to reduce the amount of bacteria on the patient's skin in their nasal passage to reduce the risk of an infection from surgery. So it involves three things. There's the CHG wipes, chlorhexidine wipes that wipe down pretty much about the entire patient's body. That's just it's like disinfecting our patients in a sense. There is povidone iodine we put that in the nose, and that's so we talked about drug resistant bugs earlier and MRSA. Patients can be colonized with MRSA. So that doesn't mean you have an infection. It just means that MRSA is in your skin, in your nose, and hanging out there. So it puts you at a higher risk for surgical site infections. Sure. So we put that solution in the patient's nose prior to surgery. And then there's also a CHG oral solution that we ask patients to gargle prior, and that helps reduce the chance of aspiration pneumonia risk
Yeah.
surgery as well.
Yeah, good. So all these things are trying to like reduce the amount of bacteria we have on our skin and other places. So that typically when you're having a surgery, someone's making an incision at some point in time. And when that incision is made, the fewer bacteria you have, the less likely you are to get an infection at that site. So, and is that for all surgeries that we do that, Gina, or do we select that out to certain surgeries?
Surgeries below the neck,
Okay.
and as long as it's not a mucous membrane, surgery that involves mucous membrane.
Yeah.
Sorry for being technical.
Right. And the thinking being, if it's a mucous membrane type of thing, it's already, you're not going to be able to completely sterilize that anyhow. Yeah. Okay. Got it.
Well, something, can I pop in really quick?
Absolutely.
We do track surgical site infections too. That's part of our job. So all of our total joints, so our knee replacements, our hip replacements, our abdominal hysterectomies, our C-sections, vaginal hysterectomies, and certain colon surgeries. So we actually track that for 30 to 90 days. We kind of keep track of the patient to make sure that they haven't developed a surgical site infection. So that is something that we also keep an eye on as well.
Of which those numbers have tended to be very good here at CGH. So
they are very good.
Yeah. Okay. I want to talk. I have one other question. At least, no, I have two other. I'm going to add. I have a bonus question for the two of you. Okay. So I'm going to segue on something you just said, Gina. That was about that. Some people have this MRSA in typically their nose. You can have other places, but they don't always have. They're not necessarily symptomatic in terms of the infection. So when people come to the hospital and get admitted to the hospital, Gina, what do we do? Do we screen them people from certain situations for MRSA before they come in? And then if they are screened, what do we do if they're positive?
Yep. So we screen any patients admitted to to CCU. So by screening, it's a swab inside the nose that tests for MRSA, the presence of MRSA. And so it's our CCU admissions, and then any patients that are coming to us from a nursing home, because there's tendency that occur more in our nursing home patients.
Yeah. So they're nursing home patients and patients admitted to intensive care are going to have a nasal swab just to see if they have MRSA. And if they do, then they go under one of these isolation precautions.
Mm-hmm.
Yep. Just wanted folks to understand that's what we do, because if we can isolate and know that person has that, then knowing that is a big deal in terms of how we interact with that patient and what we're wearing so that other people doesn't get spread to them. So, okay. So that was the bonus question. And then here's the other question that we talked about a little bit already too, about C. difficile, which is basically, help me if I'm wrong on this, but basically we already have bacteria in our gut all the time. And so it's just kind of what we live with. I think you hear more and more in the media about your probiotics and your microbiome and all that type of stuff, which is about your gut bacteria. Well, sometimes that gets thrown off, and a bacteria called Clostridium difficile takes hold in your colon, and that is not good news, and that causes a significant infection. Not infrequently seen in hospitals across the country. So I want to touch on that a little bit. And first of all, here's the question. Because I want the community to hear this too. How can taking antibiotics for an infection cause an infection? And what do you suggest for patients who are interested in getting antibiotics for an infection? So I'm talking more people that are out in the community going to an office, although we deal with that here at the hospital too. But what would you two ladies say about that?
Okay. Well, I mean, antibiotics, they kill bacteria, but they typically don't care what they kill. So they kill the good, the bad, the ugly. They kill it all. So then that leaves your intestines wide open for something else to come in. And that something else is typically C. diff. And it's a nasty little bacteria that likes to take advantage of the fact that there's no one here to fight them off. And so that's why we try to encourage people, if you're going to your doctor and you have a sinus infection, a lot of times that's a viral infection. And I know it feels good to like have a medicine to be able to take and everything, but just to know that, that can cause C. diff potentially. And also our big fear is the multi-drug resistant organisms. So that's a really big word there. But like MRSA is methicillin resistant Staph aureus. So Staph aureus never used to be resistant to methicillin. And that used to be like the big one. And now there are probably a dozen of them, different types of bacteria that are resistant to the antibiotics we use to treat them. And that is something that we are honestly kind of scared about, because that's something that, you know, we eventually might run out of something to be able to treat these with that were simple treatments before. So yeah, only ask, you know, if your doctor prescribes you an antibiotic, take it as appropriate, but try not to ask a doctor for an antibiotic. How's that?
Yeah, that's good. I appreciate it. And I, speaking as someone who has dealt with that as a clinician, I think for those who are watching, antibiotics they've been a miracle drug for the last 100 years or so, maybe not quite that, but somewhere in that time frame in terms of curing some infections that were really tough to cure because we didn't have penicillin and then all these other antibiotics now that we have. So absolutely, antibiotics can be really helpful and necessary for certain infections. But if the V word ever shows up in what someone tells you that you have, virus that is, so if you have a viral infection, and I'm going to throw in the viral infection bucket every upper respiratory infection or cold, and almost every case of bronchitis, and many cases of sinusitis. If you have any of those that are thought to be in the V category, antibiotics are not going to help that infection get better. And they could potentially, number one, cause you to get C. diff. And number two, at a population level, at our community level, every person who's taking one of those antibiotics for a cold or acute bronchitis is a potential opportunity for that bacteria to tweak itself a little bit and become more resistant. And then you or the next person who gets sick, then the antibiotics don't work as well. So I just thought it was a great opportunity having Gina and Katie here, because they deal with this all the time. And we just, there's that balance with antibiotics. They're great and they're not. So I wanted to share that with everybody. And thank you, Katie and Gina, for kind of making that clear. So I've run out of the things I wanted to ask, but I'm of course open to any other editorial comments you two would like to make.
We hit about all the hot topics we work with.
All right, good. Well, Gina, Katie, thank you for all you do, for your hard work. I see it every day, day in, day out. A lot of folks, our people that are in the community, obviously you're very silent to them because they don't see you here and there. People even in the hospital, you're kind of the folks that behind the scenes are checking on things and kicking the tires and making sure that we're doing all we can to keep people safe. So thank you so much for all you do. And thank you for taking the time, for letting me bend your arm to join me here today for Facebook Live.
Thanks for having us.
Thank you for having us. Yes.
Okay, great. So I wanted to do a couple of things before we show our video, our field trip. First of all, I wanted to give a shout out. Oh, thanks, Donna. I appreciate it. And thumbs up to Gina and Katie. So I wanted to do, first of all, shout out. We have a Daisy Award winner recently, Chuck Arwine, as an RN in our critical care unit. And Chuck recently received the Daisy Award. Chuck does a great job. I see Chuck all the time, always a pleasant fellow to run into. And we're so glad to have him here at CGH. And shout out to Chuck for the Daisy Award, which is, as you can see, for extraordinary nursing. So I wanted to do that shout out. And then I just wanted to, before I sign off and turn on the video of the field trip, I just wanted to once again talk about that. What we're trying to do here in this Facebook Live is to educate and inform you in the community. And we trust that today's broadcast was helpful in terms of doing that. Encourage you to share this with others as you feel it would be helpful for them to hear. And thank you so much for taking the time to tune in and watch. The video is going to go live in a second, but I just want to thank you for watching and wish and hope that you have a great week. Until next week, thank you for taking the time. Welcome to a field trip. Today we're up on the medical floor, and I have Miranda Benavidez.
Got it.
That last name's a tough one. I know Miranda forever, but the Benavidez is a tougher one for me to get out. But hey,
Yes.
Miranda is a nurse up here on the floor, and she's been up here for, it seems like,
Going on 4 years.
okay,
Yeah.
for quite a while now. And actually today she's the charge nurse, so which means she's kind of running the show, and she's helping us.
Yes.
Talking a little bit about what we do when patients have different kinds of precautions we need to have for them when they show up here to the medical floor. So I guess the first question I've had, Miranda, how do you know as the patients come up to the floor what kind of precautions they're going to need?
So usually we'll get a phone call from the lab that will tell us if they have anything specific in their labs that is like a positive blood culture, urine culture, anything like that.
Okay.
A lot of them we're familiar with, so we'll know what kind of isolation to put them on. Otherwise, we do have like a packet in the drawers that will tell us. And then there's these special signs that are inside of our drawers to put up there. If not, we can always ask Dr. Alkaloff too. He kind of helps
He's
us
our
with,
infectious disease
with
doctor,
other
by the
stuff
way.
that we get a few that we don't know. So.
Yeah, and if they come up and it's some sort of like you think they suspect it's pneumonia, or they suspect, that probably keys you in a little bit too about what. Yeah. Okay. All right. Yeah. And so obviously we're talking now, but I'll have talked with Katie and Gina prior to our thing showing up here on Facebook. But there are several different types of isolation.
Yeah.
And so on a floor like this, I can remember one day, it was last week, week before that, it seems like there are like 12 patients on various types of isolation, right?
Yeah.
That was a big sigh,
That's
right?
normal. I think we have like 5 today too. There's a lot. Yeah.
So first of all, how do you, for the nurse who's going to start seeing that patient that day, how does he or she know what kind of precautions it is and what to do?
So usually at our huddle in the morning, like at the beginning of each shift, day shift and night shift, we'll let them know what kind of isolation patients are on, and we just normally give them the room number, so that will help. And then there's also the signs on the walls that will help to tell us what kind of precautions it is and what you should look like when you're going in that room.
Okay. Yeah, that's a familiar face for those of you who are normally see. Yeah, somebody
Dr.
wrote
Bird on the wall.
Yeah, someone. I think our marketing department roped me into taking a few pictures a few years ago. I didn't realize they were going to show up on the walls like that. But anyhow, that's one of our visuals. And then, can you talk us through what this is, Miranda?
Yeah, so in the top drawer is usually where we'll keep like the stethoscopes that we use for the patients, and they're one patient use usually. We throw them away afterwards. But it will also have all of these different signs that give us like the different isolations that they need. Like this one's a different one for like airborne. It's just got the mask on. So that's usually there. And then as you go down, we have like all of our gloves and like booties, stuff like that we need. And then it kind of goes into the gowns and the extra supplies and stuff at the bottom. So
yeah, and I think the point is, I wanted to make for people who are watching too, that for the last 2 years we keep hearing about COVID, and that's important.
Right.
And we have precautions that we do for COVID patients, but there's a big bucket of patients who aren't COVID that you do this for as well.
Right.
Yeah. So I think that's the thing I want folks to realize, is that Miranda and her team have all the time patients up here who have some type of different thing that they need to be careful with for that patient as well as for themselves and for other patients and stuff in the area.
Right.
So yeah, I wanted to take just a moment with Miranda and talk through what we've done here at CGH to equip our rooms with what's called negative pressure. It's something that our maintenance department has done for, is it all of our rooms now, Miranda, that have this up on the medical?
All of ours have them except for our 2 like behavioral rooms. Those
Okay.
can't have them in the windows, but all the rest of them do.
Yeah, so it allows, can you talk about what that allows then?
Yeah, so originally we only had 2 rooms that we could actually put a COVID patient in that were negative pressure. And with the influx of COVID we were getting, it just wasn't working. So they installed these nice fans in the windows that when they're turned on do make our rooms negative pressure, so we're able to use any of these rooms for COVID patients as long as the door is shut.
Yeah.
And maintenance can come around and check the outside, like underneath the door, to make sure that the pressure is what it needs to be. So.
And traditionally on the floor, do you have like maybe 2 or 3 negative pressure rooms
We
all
have
the time?
2, yeah.
Yeah, and what kind of patient would typically be in that room besides, of course, your COVID
Usually
folks?
it's like a TB patient, if
Yeah,
we're ruling
yeah.
out TB or something like that,
Yeah, some type of airborne infectious disease. That's what these are for. So if you're not a patient who needs that, this is what it looks like. And
Right.
then if you do happen to have...
And we do put these boxes on also because if you don't have them on, the draft that comes through these windows is horrendous.
Yeah, okay.
It gets
there
very
we go.
cold.
There we go. So I'm going to finish this, getting this off of here, just to show folks okay. So I'll hold that for you,
Got it.
Miranda. So yeah, this is... You want to talk about that?
Yeah, so they just get plugged into the wall, and then there's 3 different settings you can put them on. I believe as long as they're just on, it'll be negative pressure, but sometimes they're very loud, so we'll move them down to the lowest we can get them.
Yeah.
Because of the drafts and stuff like that too. But
Yeah.
yeah, as long as they're turned on, it makes the room be negative pressure. There's like vents on the outside that open when the fan is on, so everything is getting sucked outside.
So the concept there is you have a patient here who's in the bed, and what is that negative pressure allowing in terms of infection prevention thing to do?
Well, it's taking it all outside, so because we're all coming through the door, and before you know, the vents and stuff would be in the ceiling. I know downstairs or in the bathroom, and everybody's kind of walking through that.
Right.
So these kind of allow everything to kind of go outwards, so you can like stand by the bed and not be,
Sure.
you know, breathing all that in. So.
Yeah, I almost think it's like almost making...
Sorry.
It's all right. Hey, she's working today. It's almost making, you know, we talk about like COVID is a lot less likely to spread when you're outside.
Right.
So it's almost making this inside outside.
Yeah.
Because it's like wind is blowing through and you're sucking that air out into the outside air. Is that kind of...
and you can kind of hear it's trying to come through now. Yeah.
Yeah, you
With
can
it
a little bit.
open.
So, all right, very good. Well, thank you, Miranda. And,
You're welcome.
Thank you for all the good work you do up here on the medical floor to take care of our patients and keep them safe and keep them free of infection while they're here and everything.
You're welcome. We're certainly trying.
Okay, welcome again. I'm continuing our field trip, and I pulled in someone from Environmental Services. This is someone who's been on with me before. This is Maria Mariggs.
Yes.
Hi, Maria.
Hi, Dr. Bird.
Maria didn't know she was going to be on doing this until about 10 minutes ago, so she was
Right.
very good sport with me about doing this, so thank you. But as we've talked about before with our environmental services team, they really are literally on the ground floor of keeping patients safe
Yes.
when they come to the hospital, and particularly if they have some type of precautions from an
Yes.
infection control standpoint that they
Yes.
need to have. So Maria, the question I wanted to ask you when we're talking about infection prevention is when there are patients in the rooms that have
Yes.
different kinds of precautions, contact,
Right.
droplet, you know, whatever.
Yes.
Do you go about cleaning those rooms any differently for those particular patients?
Yes, I do.
Okay.
We have these cards that we put on the outside.
Yep.
And what we do, whatever the sign says, we do, because some people may come here with just an infection. Some are here reverse isolation,
Yeah.
and whatever we take in, we
Yeah.
could make them sicker.
Yeah.
So we have to make sure that we sanitize our hands, do everything like we should.
Yeah.
And so whatever the sign says, I do.
Okay.
And sometimes we have to do it with bleach.
So
Sometimes
who would you do, what kind of patient would you do bleach with? Is that more the contact?
yes, it's contact plus it's C. diff.
Yeah, so,
Everything has to be done with bleach, and then we rinse it all off.
yeah,
And so
yeah,
it's a pretty nasty infection, so you really want to
right.
clean it really, really good.
Yep, yeah, Maria's team does a great job with that. And so, yeah, we've already talked about C. diff in the interview I had with Katie and Gina.
Yes.
But I wanted to talk to someone who on the front lines is dealing with that. So you're using bleach
Yes.
for those patients while
Yes.
they're here and when they leave?
Yes.
Okay.
Yes.
Okay.
And then we use a robot, because I tell you what, I talked to a patient just the other day, and she was so happy to know that we had the robot, and the robot kills C. diff, MRSA, and all these other infections. They
Yeah.
were very happy to hear
Now,
that.
when we say robot, just so folks know, because we've...
I'm sorry.
No, it's all right. It's all right. So talk a little bit about what that robot does and how it does it.
The robot, we have one now, and it's about this tall, and it comes up, and we use it 15 minutes in the room, and it kills it's ultraviolet light, and
you
it goes around the room.
Sure.
And we put it in the bathroom too, and in the bathroom it gets it really, really well too.
Yeah.
And it kills C. diff, MRSA, COVID, any of the infections that we
Deal with on a
deal
regular
with
basis.
every day.
Yeah.
You know, and we had the robot before
Yeah.
we had COVID.
Yeah.
And so people are very happy about the robot because if they feel like it's an extra precaution,
Yeah.
an extra security for them.
Sure.
And so they're very, very happy about that.
Yeah, and just to clarify, I mean, if we didn't have a robot, your team would still do
Right, we would.
It'd
We would.
be a
But
good
this is
enough job,
second.
but just an extra layer of protection
Yes.
to what you're already doing for
Yes,
infection.
and from time to time, a patient asks me, and I give them a little bit of information, and I show them where their website is so they can look
Yep,
it up.
yep.
And they're very happy about the robot.
Yeah, but they should be happier about you.
Yes, yes, yes.
Because your team does
Yes.
a great job of
Oh,
getting the room
yes.
clean in the first place, and then the robot just is a
Oh,
little extra layer.
Yes,
So.
yes, it is. Because
Yep.
I tell you, like, I've had one person ask me, "Do you just put it in there?" I said, "Oh no, we have to do everything first.
Yep.
Everything. We have to wipe everything, and then that's a secondary."
Right, right.
Yeah, but
Yep. So literally, this is one of the folks that on the ground floor helps to keep the hospital and our patients and staff and everyone safe. So Maria, thank you for all you do.
oh, you're welcome. Thank
you for being a good sport on short notice.
Well, thank you, thank you. I'm
All
glad
right.
we can educate people because it's so important.
It is. It is.
Yes.
Thank you.
Well, thank you.
Yeah.